you want to move to the next slide. So what webinar wouldn't be complete without a little disclaimer here. I'm not going to read this for verbatim, but just wanted to make sure everyone was aware that's listening that this presentation could contain some forward-looking statements. And obviously, since we're in the healthcare technology space and we're not fortune tellers, our perspective versus what may or may not happen in the future could differ. So just wanted everyone to be aware that you've considered yourselves informed on our safe harbor statement here. Next slide, I'd just like to make sure everyone knows how to submit and ask for questions. Due to the number of attendees, all the participant lines are muted. And if you'd like to submit a question at any time, click the orange arrow in the upper right of your screen, and that should open up a question box. If you don't see the orange arrow now, I'd also refer you to just email those questions to that same email address I gave you previously at marketing@connecture.com. I'll be monitoring people's questions through the presentation for anything urgent, but we kind of want to respect everyone's time and try to keep this webinar within the 1 hour time slot allotted. So at the end when we get to questions, we'll go ahead and start digging into those. But I just want to make sure that you're aware of it. If there are too many questions and we can't get to all of them, we will be sure to personally answer your email after the webinar, since we should have everybody's contact address. So I think that's a little bit of housekeeping there. Since I'm not sure, if everyone is really familiar with Connecture, and I know we have some attendees on the line that maybe don't contract with us currently, I thought I'd try to level set a little bit for the group with a single slide. Essentially, Connecture, we're a technology provider in the healthcare industry that focuses on member acquisition, and that's inclusive of shopping, quoting, and enrollment solutions for all ages. So that would include IFP, both on and off exchange, group, and Medicare. We also provide member engagement and retention automation solutions. We were founded in 1999. We're headquartered in the center of the U.S. hotbed of technology, Brookfield, Wisconsin, in case people weren't aware of that. We also have offices in Atlanta, Farmington, Los Angeles, and Raleigh-Durham. We've got over 100 customers, including 20 of the largest 25 carriers in the country and more than 50% of the Blues. Our platform serves about 20 million plus consumers each year, providing them with the tools that they need to help help them with decisions on really their healthcare insurance needs. So with that, I'll move to the next slide, where I'd like to introduce our speaker today. It's Matt Parker. Some would say he's the better looking guy on the left, but I would beg to differ. Matt began his career in healthcare technology back in 2002 when he built and architected our Drug Compare platform with the founders of RxExaminer, who had the vision to help patients understand the cost of their medications and improve their adherence. That vision is becoming a reality today, reaching over 100 million consumers with access to the tool, who obtain more than 30 million comparisons per year. In 2005, Matt built the technology behind Medicare.gov site and the DRX commercial Medicare Plan Compare product. He then further expanded the use of the technology through the development of Connecture's suite of APIs, now with over 130 million transactions per year. In recent years, Matt launched the Connecture SaaS platform, which enables the deployment of over 250 Medicare, IFP, shopping, enrollment, and drug compare sites annually. Now that I've given Matt a little larger head than it actually appears on the screen here, I'm going to go ahead and ask him to get us started. Thanks, Matt. The floor is yours.
Thank you, Tim. Welcome, everyone. As Tim said, we're here to talk about the Texas legislation, HB 1624, which passed last year. What this legislation is intended to do is to provide information and consistent and clear information to individuals around formulary and costs for drugs within those plans. And we're here to discuss how our experience powering Medicare.gov's Plan Finder, formulary and price comparison tools, as well as our existing DC product, Drug Compare product, allows us to provide an out-of-the-box solution for plans to comply with this legislation. One component of the legislation is with respect to displaying formulary and drug cost information on an internet website as defined by the legislation. They have identified the requirements are that formulary information must be made available via a direct enrollment link, electronic link placed conspicuously within the SBC for each plan sold on the insurer's website. And the information must be publicly available and accessible without entering a username, password, or any personally identifying information. And what we want to talk about today is how each of the components of that legislation are met by our suite of products, and then we'll get into some additional benefits of those products as well as a demonstration of the tool. So the first element of the legislation is that it can't simply be a PDF or other static material. It needs to be electronically searchable by drug name. What we wanted to identify here is that our drug search is a market leader for our internet sites today. We can search by name, which is required by the legislation. In addition to that, we can also enable smart searching with type-ahead functionality, allowing users to not struggle. And one of the things that we've seen with our Medicare experience is that users often struggle with how to spell their drug names and how to identify what dosages they're taking. So we've built a number of features into our drug search capabilities that overcome some of those challenges and allow for a drug name search that's usable by non-clinical consumers. So again, that includes smart search functionality with type ahead, allowing a user to begin typing their drug name and select their drug from a list. We also include sounds like search results, enabling users who mistype or misspell their drug names to be able to find their drug in spite of their misspellings. And in addition, because formulary and pricing information is often provided at the dosage level versus the drug level, we do allow for users to select from dosages and quantities and specify those dosages and quantities within their drug search, but we do pre-fill for users the common dosage and quantity of a drug so that they are, if they are unaware of their dosage or quantity, they can use the default to get information. The legislation additionally requires that detailed information about cost-sharing tiers, including the coinsurance amounts for each drug, be presented. It is not enough in this legislation to just say this set of drugs are on the PDL, this set of drugs are covered as a generic. It needs to explain to the user what that means for them in terms of cost estimation and cost sharing. All of our products include today cost sharing information that includes an estimate of the total cost of the drug, an estimate of what the members' cost share would be based on their plan design, i.e. if it's a copay tier, what their copay would be and the balance to be paid by the plan. If it's a coinsurance tier, what the percentage of the coinsurance factors out to and calculates out to based on the total cost of the drug. And we do include in all of those estimates both the pre and post deductible amount, what a user would pay before they've met their deductible and after they've met their deductible. And for Medicare plans, we would include all phase costs, including deductible, initial coverage level, donut hole, and the catastrophic costs. One of the more difficult elements for users to understand is what really a formulary is and how that works for them, because it's not simply from a non-health plan informed user. The idea that a drug is on or off formulary or covered or not is just the start. understanding how it's covered by the plan, what utilization management programs or limitations may be present on the drug, and any alternatives that could exist under that formulary are all key components of what a member would need to understand about the drug's placement on the formulary. The specific requirement in the legislation is to disclose prior authorization, step therapy, or other protocol requirements of the drug. What we do in all of our products, and what we'll show later today in our demo, is that we do cover today all of this functionality. We identify for every drug where it sits on the formulary, its tier placement, and we include the ability to display prior authorization, step therapy, and quantity limits for all drugs covered by the plan. Those quantity limits can include the days of supply and the quantities covered. Prior authorization can be integrated in some situations with electronic prior authorization tools, and step therapy can include descriptions of what steps need to be taken before that drug would be accepted. Additionally, the legislation requires a simple and easy way for the user to identify which formulary applies to the plan that they are considering or have already enrolled in. And once that formulary is identified, they want to be able to identify which drugs are preferred, what the coverage rules for each tier of coverage are, and how which plan that formulary is connected to. As you'll see later in our demo, our tool is searchable. The plan can be selected. The formulary would be identified by the plan, and all of the formulary information that's required by the legislation would be present on all of the screens that the user would be interacting with during their use of the tool. So now I want to talk about our Drug Compare product, which is our solution for this legislation. This product has been around. This product is the most well-established and comprehensive online drug and price comparison solution that's available today on the market. We have been around for over 16 years. Last year we had 31 million comparisons run against this technology across all of our installations. Pricing and formulary information is available for any drug covered under the drug benefit. And in addition, we have over 150 therapeutic classes of drugs with comparative effectiveness therapeutic alternative data available. The tool is available today across all of our installations, covering over 100 million lives. And we have over 12,000 therapeutic alternative comparisons available within that data set. What this tool allows users to do is to compare their costs and their options under their plan and formulary. Our therapeutic alternatives are mapped at the dosage level and provide clinically appropriate, comparatively effective therapeutic alternatives. What I mean by that is all of the alternatives, the options that we display in our tool have a similar therapeutic outcome as the drug that would have originally been prescribed to the user. It enables a user to bring a report to their physician to switch prescriptions with the appropriate dosage and quantity already identified, saving the provider time and represcribing an option. It allows for a higher uptick in adoption of the recommendations by providers because they don't have to spend time kind of researching what's the appropriate dosage of a formulary option. Additionally, this content and information is available and integrated with all of our shopping and enrollment tools so that any user selecting and choosing a plan has access to formulary and drug cost as part of that enrollment solution. I mentioned earlier our experience with Medicare Plan Finder. I think this is most evident there, where a user would be entering their drugs and formulary as part of their plan selection process, and the plans would be sorted appropriately by formulary coverage, cost, etc. And additionally, while I'm going to demonstrate later our hosted solution, our white label solution, all of the functionality that I'm discussing here today and will be demoing later is available in Web Service API, which would enable your organization to integrate and meet the legislation's requirements, but integrated in the experience that you've already built up for your members. And that would enable you to not need to build new functionality around how to track and log formulary, how to provide the formulary alternatives to users, how to do the cost estimation, but you could integrate it, again, directly within your application. What makes DrugCompare unique in the marketplace is that DrugCompare really makes transparency an actionable event for a user. So rather than providing price information, or rather than providing drug information alone, we've married these two together. So our broad and comprehensive comparative effectiveness data allows us to provide the largest set of drug comparison information to users, allowing them to consider what their therapeutic alternatives are. And we've combined that with the formulary plan design and pricing under their benefit, so that they're not just looking at drug information and getting interesting clinical content. They're actually able to see what the costs look like, what their coverage limitations are, any utilization management, and actually do something with that comparison information. We really focus on 4 challenges mostly related to drug cost and formulary compliance, but also benefits like adherence and engagement. With cost, because we've married the clinical comparison data with formulary and benefit design, we're able to give users very, very specific and real cost comparisons between their treatment options. By giving them a more accurate and specific cost recommendation, they're able to take action on those comparisons in a way that simple formulary compare tools aren't able to generate. Additionally, access to this cost information and the therapeutic alternative data allows for a higher generic utilization rate to be achieved by the plan, because you're not relying simply on generic equivalents that the pharmacy can dispense without a prescription. You're actually providing generic alternatives and recommendations for many drugs that are still on patent. The ability to drive a higher utilization of better formulary and lower cost drug options has a very a beneficial effect on drug adherence. Drug adherence is important because if members are taking their prescriptions and they're trying to save money by taking them without following the prescription plan that was prescribed by their physician, those treatments are less effective. And as a result, the costs that are spent on those prescriptions are wasted, and you can likely have poorer health outcomes in the long run. And additionally, members are frustrated. We know this. We've been testing and surveying users for a number of years. All of our research indicates members are frustrated as costs continue to rise, and they're frustrated for a number of reasons. They're frustrated not because the costs are going up. They're frustrated because the costs are going up and they're not empowered to do anything about it. It's one thing to shift costs to members to try to drive market forces and get members to to shop smartly for their drugs. But without the tools to compare cost, safety, and efficacy, they can't actually be participants in that bargain. And as a result, their frustration continues to grow. So we focus our clinical research on, in our therapeutic alternative data, on the drugs that members are asking for the most. Over 60% of the drugs that are searched in our platform, we have therapeutic alternatives or savings recommendations for. And for a number of the drugs that there are no savings opportunities for, many of them are already lowest cost drugs, and the balance are drugs that are taken typically in a non-chronic setting, like antibiotics or vaccines, etc. And we've spoken a little bit about cost and savings, but we really believe that what we're offering to users and what's important for users is not just a way to save or to understand what their costs are, but to make sure that they're meeting their clinical needs. And what that means is that they want to know that their options will save them money, yes, but also be safe and equally effective. So all of our tools and all of our engagements with customers around our clinical comparison information is really targeted to these three pillars of consumer engagement, which is saving, safety, and efficacy. We don't provide recommendations for users for drugs that don't work as well. We don't prescribe, and when we very prominently and carefully promote to users what side effects and drug interactions and how those compare between their options. What does this mean? How does this all add up? Well, in 2015, we ran over 30 million comparisons across our platform, and each of those comparisons in average or in aggregate had an annual savings of around $900 a year. That'd be split between the health plan or the payer and the member. But on average across those 31 million, we saw an average savings of $900, which is a potential savings, assuming that every prescription was rewritten or rerun at the lowest possible cost, of a little under $30 billion in total savings. And what we see in our tools, in our deployments, is around 11% of users who run a comparison will actually go and switch those prescriptions. We've run those through claims analyses and surveying our customers who are using these tools. So we see about 11% of those 30 million comparisons will actually result in a lower cost prescription being applied typically at the next refill, which translates to a little over, just slightly over $3 billion of savings that has been created by this technology in last year alone. I was doing this. I was presenting these numbers to a customer the other day, and their eyes somewhat glazed over at this number. And and I put it in context. If you're taking a brand drug that costs $200 a month, and there's a generic alternative that costs $40 a month, that's $160 a month savings. When you spend that over the course of a year, it's almost $2,000 in savings. Again, that split between the payer and the member. To a member, that's very real information, even if it's only a $30 or $40 split based on the co-payer plan design. And for the payer, that's very, very real money that they save in aggregate across their entire populations. Now, I mentioned briefly earlier that we go beyond generic equivalents, and we do cover, obviously we do cover generic equivalents in our data set. And generic equivalents are those that are chemically identical by the deemed that way by the FDA. Those can be substituted without a new prescription. Those would be typically done at the pharmacy counter by the pharmacist directly And so this is the typical way you get generic utilization within a plan, or the prescribing pattern would be this sort of switching. Sorry, it looks like the page slipped by itself. But we go beyond those, and we include generic alternatives, which would be generic drugs that are similar, that have similar effectiveness of a brand drug that's still on patent. We do cover and help promote the formulary tiering, and so many times preferred brand drugs will be cheaper even if there are no generic alternatives available, and so driving formulary compliance by helping members who are being prescribed non-preferred or off-formulary brands into a preferred brand setting. And additionally to those standard formulary options, we also include for a number of our categories over-the-counter options. Obviously the over-the-counter options save the plan significantly, but usually are also very cheap, usually offer significant savings to the members as well, and can provide a similar and maybe even better effectiveness for that treatment. And lastly, we have as some optional configurable additions to that clinical data would be alternative dosing options. One way to save aggressively for members would be to engage with things like every other day dosing for categories of drugs that can work that way, as well as pill splitting for drugs that can be split. The costs for a double dose of a drug often are only slightly higher than the half dose option, and by splitting that dose you nearly split the cost of that drug as well. Those options, many plans, and just to be clear, many plans do not want to promote those options to their members, and these are all configurable and may or may not be turned off or not displayed to users depending on your clinical oversight. Now, I talked a little bit about that $31 billion or that $3 billion in savings. How does that translate? How does that translate to a health plan? Obviously, that $31 billion is aggregate across all of our customers, and that's the 100 million. I mentioned those 100 million lives that have access to the tool today. What does that mean for an individual carrier? Well, we modeled that out. We've modeled this out. We modeled this out for a number of different carrier sizes, and for the purposes of today's call, I wanted to talk about just a model carrier with a little under 1 million lives, about 700,000 lives. We see normally within those 700,000, within a normal population, about 10% of users actually actively engage the tool. That 31 million comparisons we ran would reflect that kind of the post 10%, right? That's the 10% of users actually engaged the tool, generated those number of transactions. With an average savings, again, of $900, as we talked about earlier, and a conversion of 11%. So with those 700,000 members, what we would expect to see of a total savings available from that activity is around $63 million of the drug spend would be lowerable by switching medications. And that would be, with the expected conversion rate of 11%, around $7 million in savings available for that specific plan. And then, with the split and the share of that savings between the payer and the member, that payer would expect to save right around a little over $5 million. Now, I bring this up especially in relation to this legislation for an important reason. The legislation is asking plans to put this information out there, but what we want to point out is that that's an opportunity. Putting this information out there to members allows for the plan to make real cost savings and generate real cost savings for both themselves and their customers with that transparency. So the legislation doesn't have to be a burden. It actually can generate a significant amount of cost savings if done well and right. So we see this legislation really as an opportunity and not as a burden. It allows for members to have better decision support as they're comparing what their plans, what their plan options are. It allows them to get into the right plan. If they have a certain drug profile, a certain drug regimen, that plan is really set up to be effective with. It helps users get that plan. We've done some research internally in terms of where members who have access to this sort of decision support go. Oftentimes, the members who use these decision support tools have a significantly higher uptick on higher premium plans. Members who engage with decision support are picking higher premium plans than those who simply choose based on premium. Additionally, these tools allow users to pick drugs that they can afford, which improves their prescription adherence and results in longer-term healthier outcomes, which will reduce overall long-term costs of members by keeping them on lower-cost prescription regimens now to avoid higher-cost hospitalizations and interventions later on. Transparency. This legislation and our tools will allow your plan to move to the forefront of price transparency, to give access to individuals real information about costs and options under their formulary in ways that they can actually take advantage of. We didn't spend any time on the webinar today, and we can talk about this if you're interested in future discussions. But one of the big areas of opportunity with this technology is helping to explain specialty drug costs. We have our technology includes the ability to help users find ways to save with specialty drugs and to take factors such as why they're taking the drug, their age, weight, or gender into account when presenting their options, which allow us to expand those 150 therapeutic classes we talked about earlier into these expensive specialty drugs. You know, the other area here for health plans to consider is that these tools, many of these tools are available behind the login by your PBMs. But by providing these tools to your members directly, this is an opportunity to keep your members close, to see what they're searching for, to understand what they're struggling with from a cost standpoint, and allow users to prospectively enter drugs into the system for comparison before they've had prescriptions and before you've even seen claims history come back. And the last kind of real opportunity with this tool is we do integrate with your pharmacy networks, and as a result, narrow networks in the pharmacy space are growing. They're fairly prevalent in Medicare today, and they're growing in the under 65 market. And our tools all work within that context and allow users to have greater adoption and less member confusion around narrow pharmacy networks. Now, I've spent a lot of time talking about the benefits of our drug compare solution. I do want to spend a little bit of time talking about the extensive amount of work that goes into it from our clinical team around maintaining and growing and maintaining that clinical content. All of our 150 categories of drugs go through annual reviews. Some of them go through even more frequent reviews than that. We have a team of pharmacists and physicians that build and maintain this database. They're reviewing the literature. They're reviewing studies that are being done and released. They're reviewing FDA guidance and other manufacturer guidance about safety and interactions. In addition, we have a team of active physicians who are part of our clinical team. These are physicians who are live in practice today. who are taking into account practice guidelines, real-world practice implications of all of these therapeutic switches. And additionally, we go through an editorial and we go through ongoing maintenance reviews. So all of our clinical data is being very, very actively managed by our clinical team. In our clinical, I mentioned our clinical review board. We do have 2 PharmDs as well as 7 additional physicians who are actively participating in this clinical development. Now at this time, I'd like to jump over to a demo of our application. I want to be cognizant of the time, so I'm going to move through the demo. I'm going to kind of highlight some of the features that are called out by the legislation, and obviously we'd be happy to have any additional follow-up conversations or deeper dives into this application, and you can follow up. You can follow up either through the questions or the marketing links that, or the marketing emails that we mentioned at the beginning of the presentation. But I'm going to go ahead and jump over to that real quick. So this demo we have today is a demo in which the user is not the user doesn't currently know which plan they are in. This is one, again, a component of the legislation was the ability to pull up a formulary and plan design through a searchable interface. In this case, this plan is offering a number of plans for use, and an individual wants to consider, let's say, I'll just pick 2 plans for today, and they've selected the plans we've now engaged the plan design in formulary for this user, and they're going to go ahead and search for drugs to find what the cost and formulary comparison. Now, I'm going to go ahead and search for a drug here. Again, the legislation requires that this be an electronically searchable interface. I'm going to go ahead and search for a drug here, and as you can see, as I start to type, options are coming up, and I'll go ahead and pick, I'm looking for Crestor today to manage my high cholesterol, and I'll go ahead and select that. Now, as I mentioned at the beginning, all of our drug searches include the most commonly prescribed dosage and quantity. This gives the user the ability, this gives the user the ability to not have to know what their dosage and quantity is. Again, that may seem silly. You may think that everyone knows right off the bat what their prescriptions are, but our experiences are in the market testing that we've seen show that many users know the name of the drug, but don't necessarily know what their dosage is without having to go and look up and pull the prescription out of their medicine cabinet. So we allow the user to kind of default at the most common. If they want to change their dosage, they can, and we do allow for them to change and select a different dosage as well as change the quantity or frequency. But we do, as I said, pre-fill this at the most common. We do include pill information, and if you were to click this drug, this would take you to the patient education leaflet that would provide detailed information for that drug, again written for them at a non-health professional level. And what do we show? So once the drug has been loaded, we immediately show the formulary coverage, the utilization management. Now it looks like this carrier's plan for this drug, there's not a discrepancy between the 2 plans, but so there's prior auth required for both the bronze and the silver. But this would allow you to show right off the bat whether there's a prior auth, quantity limits, or step therapy, and this is again baked right into the existing out-of-the-box solution. Now we don't have it in this demo today, but this would be linkable or could be linkable to an electronic prescribing or prior auth criteria list, and you could provide again even additional detail around this. And now importantly, because of this drug's formulary status, we're able to calculate the cost to the member under this plan design. And for this particular drug, we're going to show the user what their copay would be, or their coinsurance would be if it's a coinsurance plan, as well as what the total or the pre-deductible cost would be for that user. Everything here is configurable, and any text or content or labeling changes to meet your plan's brand guidelines would be able to be incorporated into this display. Now, once I've looked at this drug and I've confirmed that I'm on the right dosage, this is where we're going to actually show the user formulary alternatives. Now, based on this drug and the clinical outcome, we're able to identify 2 formulary alternatives for the user. This drug is still on patent. There is no generic equivalent for it, but we do have a generic option that under this plan looks like they're treated as a brand drug even though it's a generic, that would be what the lower cost copay would be. And then we also include another brand drug that's available for the user that is a lower total cost, which would help them before they've met the deductible. Now, I want to add this and save this drug to my medicine cabinet here. What this does is allow the user to maintain a list of drugs for their session. And why this is important is this allows you to get to another depth of detail, another level of detail required by the legislation, which is to explain how all of the tiers of coverage apply to the specific member. And so, again, this user only has one drug in their cabinet, but under the 2 plans, I'm able to show the user for that formulary and that plan design how their drugs, how the drugs are tiered by the plan and what the liability is, and where this drug sits within that plan design. I've shown this page in a number of demos of this, as well as user tests. And one of the things that was most interesting to me in a user test of this page was that a user who had about 7 drugs that they've been taking, fairly active in their formulary. They kind of understood how health coverage worked, but they looked at this page and their first thought was, oh, that's what a formulary is. And I know, again, we sort of all, in the industry, all sort of would laugh or scoff at that sort of reaction. But I think for most individuals, they're given these industry terms, they're given these printouts, these PDFs, these giant packets of information at the beginning of the plan year, and they don't really have a way of making that information real or personal to them. And I think we really focus hard on trying to make formulary and cost and plan design understandable to users. And so that's our focus on, that's really our focus on this, is to put transparency out there to allow users to compare savings, safety, and efficacy, and to be able to make informed and conscious choices about their prescriptions and their health. Thank you for sitting through this today. I'm going to go ahead and jump back over to the presentation and I think open it up for questions. Tim, have we received any questions that we can focus on?
I've received a couple here, so maybe we'll start with this one. We had an individual asking, for this solution, how long does a typical kind of deployment, with the legislation coming up and, Medicare AEP coming up, how long does this solution, would it take to deploy?
Great question. So we see typically between 30 and 45 days we can roll this out. The implementation would normally look like a short period of requirement gathering, and which then would be translated into a configuration plan for our implementation team. We would do a bit of data loading to get the formulary and plan design enabled in the application, and then there'd be a period of testing where you can test the configurations, confirm the formulary and plan data that has been loaded, and then would deploy that to your customer base.
Perfect. And then as kind of a follow-up on that, there was a question of we talked quite a bit about Medicare, but they wanted to validate this will work for both Medicare plans as well as commercial plans. That was kind of a question.
Yeah, that's another good question. Yeah, so the history of Drug Compare actually grew out of commercial and small group plans and actually moved into Medicare. And so yes, the drug compare solution works with all plan types. The plans that I was just showing in the demo were actually under 65 IFP plans. Most of those 31 million comparisons were actually done, that we talked about earlier, were done in a group context. I think it was about 60% of those are group, and then 40% of those are split between individual and Medicare plans.
Perfect. One other question that's come in was, do the alternatives presented, do they override or conflict with the formulary?
We get that question. We actually get that question a lot when we do these presentations. An important component of our clinical recommendation is an independent. It is an independent data source that the health plan would be layering into their communications with their members. However, as I mentioned, it's married carefully with the formulary and plan design, and so what you're presenting to a user is those independent options and comparisons, but in the context of the formulary and plan design that you've already established. And so we'll often see, a non-preferred drug for one carrier is a preferred drug for another, and the placement in the list of options and the presentation to members is filtered through the lens of that formulary. So we see this truly as an additive feature and not in conflict with the work that your P&T committee has already done to establish, or your PBM's P&T committee has done to establish formulary coverage.
Perfect. Thanks, Matt. We've got another one come in, and I'll throw this out to you, and I'm not sure if you have an answer for it, but the question came in that said, do we have any visibility on what drove or caused the state of Texas to implement, adding these requirements, and are we seeing some of this legislation? Are we seeing their churn in other states looking at similar requirements? Do we have any visibility to that?
So we've had a number of conversations with some industry members in Texas in particular around this, and I think couple of the driving factors that we've divined out of this are around transparency, right? The legislation wanted to make sure that individuals buying insurance in Texas are able to have access to price and formulary information as part of the buying decision and as part of having those plans Now, one of the things that we've heard was kind of a key driving factor of the design of the legislation was that the Plan Finder application on Medicare, which only covers Medicare plans, provides all of this content. We built that functionality for Medicare. We've put that functionality out there and been managing that since the Medicare Part D legislation went into effect. And that, why wasn't there a version of that functionality available for non-Medicare plans? And so because most of those under 65 plans are under state departments of insurance regulation as opposed to federal control like Medicare, Texas sort of acknowledged that they would have to be the ones to force that legislation, or force carriers to put that information out there. Again, I don't, that's information we've gleaned through conversations with industry officials and legislators in Texas, but none of that's gospel, but I think that's sort of our interpretation of this legislation is really to try to get Texas under 65 and group plans on par with the information that you can get if you're buying a Medicare plan.
Thanks, Matt. Just had another one roll in. You talked about narrow network pharmacy and pharmacy integration, and does this have the opportunity to give you some of that cost transparency all the way down to the contracted pharmacy?
Yes, it does. So all of our applications take pricing in plan design, down to the pharmacy level. Now, not all the legislation doesn't specifically require that to be displayed, and not all plans are able to or are interested in presenting that level of granularity in their tools. So we have the ability to kind of show pricing formulary, pricing and formulary information sort of on the spectrum of down to the pharmacy level, to the chain level, to the network type level, or in aggregate. So we take that as that's part of the implementation plan. It's part of the data aggregation step when we would deploy this functionality. And it really becomes a question of what level of transparency do you as a carrier or do you as a plan want to put out there for your members.
Perfect. Here's one that came in that I can actually answer. Someone was asking if they could get a copy of the link to this webinar, and yes, we did record this session. And what we'll do is, for anyone that was registered, we'll send you out an email with a link shortly with a video so that you can pass it on to other individuals in your organization. So just wanted to clarify that. With that, I don't have, I'm looking, no other questions have been sent to me here. So unless there's any other further questions, I just wanted to take the opportunity to thank everybody for joining us today. And if you'd like some additional information, or if you want to schedule more of a consultative strategy session or a more extended demo with some of the Connect Your Thought leaders, we'd be happy to reach out to you and schedule that. And you can reach us through, again, the email address that's on your screen there that says marketing@connecture.com. And I just want to thank everybody for attending today.
Thank you all.